respiratory rate increases. It's driven by progesterone, and so she's going to blow off CO2. Her heart rate increases, cardiac output increases, and a lot of blood flow is diverted to the growing uterus or the growing fetus. Peristalsis slows down significantly from progesterone, lovely, and the upper esophageal sphincter actually relaxed from that also. Total body water increases 6 to 8 liters during pregnancy, and you have an increase in your GFR. And also, particularly during pregnancy, you have decreased binding, and so that's really important to think about when you're prescribing these patients during pregnancy. And then the hormones, so you have estrogen, you have progesterone, you have prolactin, oxytocin, and a little bit of cortisol. So what happens after mom delivers the baby? Everything just returns to normal, right? Right? No. Okay. Estrogen and progesterone. Estrogen is secreted by the ovary in the non-pregnant female, and it's secreted in large amounts by the placenta during pregnancy. Progesterone is secreted in the latter half of the menstrual cycle by the corpus luteum. It's also secreted by the placenta during pregnancy as well. Both estrogen and progesterone, they increase during pregnancy, and once a mom delivers, they drop down significantly. So we know that the decline or this magnitude and change causes symptoms of depression in postpartum women. We think it may be linked to anxiety, but there's no literature out there that really says that's true. Prolactin and oxytocin. They're necessary for milk production and letdown. Prolactin kind of follows the same path as progesterone, so it increases just like estrogen and progesterone, and then once the baby delivers, or the baby's delivered, it drops down significantly. And then you have these intermittent surges whenever the mom's breastfeeding, if she continues to breastfeed. High prolactin and oxytocin activity, they're known to be anxiolytic in humans and animals. And low plasma prolactin levels are associated with stress in mothers, both lactating and non-lactating. There's one caveat to this, though. The peripheral levels of prolactin and oxytocin don't necessarily correlate with what's going on in the brain. Oxytocin specifically, it doesn't cross the blood-brain barrier. Only 1 to 5% of the oxytocin actually crosses. Prolactin's a little more, prolactin is able to slide through the blood-brain barrier a little bit more easily. But there's some thought because the hypothalamus has prolactin and oxytocin producing neurons that project to different areas of the brain. And there's some thought that these neurons actually are actually better at regulating anxiety than the peripheral levels. So I think that the research is going to head towards that direction, but I don't know how we're going to do that. Cortisol. Free cortisol is the amount of unbound and metabolically active cortisol. It doubles during pregnancy by the 3rd trimester. High levels during pregnancy are associated with lower birth weight and premature birth. We know that elevated levels of cortisol are present with anxiety and depression during late pregnancy, but they're not elevated in just anxiety alone or in depression alone. And there's no studies of what's happening in the postpartum period. So our treatment goals in women with anxiety who are pregnant are to reduce symptoms in the patient and therefore reduce perinatal complications. Some of those complications include low birth weight and low APGARs. And also we want to reduce the long-term consequences in children such as ADHD and anxiety. Anxiety in mothers left untreated during the postpartum period has negative effects on child development. They have delayed physical growth, delayed cognitive and social development, increased anxiety, and other psychiatric disorders. And mothers with anxiety are less likely to breastfeed, touch, speak to the infant, and attach. True or false? Anxiety and depression are often comorbid, and both can present during pregnancy and postpartum. However, the overall rates of postpartum anxiety disorders are lower than that of postpartum depression. Who said that first? Oh, you would. Right on. False. The overall rates of postpartum anxiety disorders are higher than that of postpartum depression. We have to remember that the childbearing age is where a lot of these anxiety disorders actually present. And then childbirth itself is a major life stressor. Oh, here you go, Leigh. Oh, 25-year-old female, G2, P2, 4 weeks postpartum, and she's breastfeeding exclusively. She has excessive worry about returning to work. She has 8 weeks of maternity leave where she cares for her infant. During the infant's naps, she would organize her pantry and linen closets, but she could never get it just right. She returned to work, but worried about her son. She pumped during the day, but had difficulty with coworkers complaining about her breaks. There was no designated room for her to pump, so she would go to the bathroom. She began having panic attacks after meetings or when speaking with her boss. She began calling in sick. She had a relief of anxiety symptoms when with her infant. You're going to have to excuse me. I'm trying to get over a cold. Panic disorder. Recurrent unexpected panic attacks. 1 month concern about additional attacks, worry about the consequences, or a behavioral change related to the attacks. Symptoms of panic attacks include shortness of breath, heart palpitations, sweating, shaking, choking, fear of losing control or dying, chest pain, dizziness, numbness, tingling, chills, feeling hot. Postpartum panic disorder. In panic disorder, symptoms typically improve during the pregnancy, and they tend to worsen after delivery. It's thought that progesterone may have a role in this, as it may be anxiolytic. New onset appears in the first 12 weeks postpartum, but there's no precise evidence connecting panic disorder with changes in the steroid hormones. Although there are no published predictors of prenatal panic disorder, studies show that there is a link between lactation, weaning, and panic symptoms. The studies show that weaning exacerbates symptoms of panic, and mothers who are breastfed or who breastfeed have lower panic attacks during the postpartum period. Obsessive compulsive disorder. Either obsessions or compulsions. Obsessions manifest as intrusive thoughts, impulses, or images, and they're typically anxiety-provoking. Compulsions, on the other hand, are repetitive, ritualistic behaviors or thought patterns that attempt to reduce anxiety. The behaviors are ego-dystonic, meaning the person is generally aware that his or her behavior is excessive or unreasonable. The obsessions or compulsions take up a significant amount of time during the day, and they interfere with normal functioning. When screening for postpartum OCD, I typically say to the patient, it's not uncommon for mothers to think about harming their babies. It happens. You're sleep deprived, you're exhausted, you barely got a shower in today. So has this ever happened to you? To normalize this thinking helps elicit information and for the clinician to better diagnose and treat. And of course, it's also important to elicit the frequency, the intensity of these thoughts, and the intent as well. Mothers with OCD, they may present with what-if scenarios. What if there's a knife on my kitchen table and my baby's running around in the living room, and then all of a sudden I grab the knife and something happens and then there's blood everywhere? So they have these scenarios of what if, and then they tend to avoid whatever is triggering that thought. So that mother who's got the fear of the kitchen or the fear of the knife, she'll get all her knives, put them in a box, and then lock them up in the garage, or she'll cease to cook, stay away from the kitchen. So they avoid objects or being with the infant to decrease the chance of acting on their thoughts. They often feel guilty about neglecting the infant, and it's very ego-dystonic. Symptoms tend to prove after delivery. The most common obsessions in the postpartum period: contamination, about 66%, symmetry, 33%, and aggressive ideation towards the infant is 33%. Compulsions, about half and half, cleaning and checking. And a note on postpartum psychosis, these patients, their homicidal ideation is egocentric. They also have delusions. A lot of them have delusions about their baby's having fire coming out of the ears. There's something different. And it's not associated with any kinds of fears or rituals. Post-traumatic stress disorder. Exposure to a traumatic event in which an individual experienced, witnessed, or was confronted with death or serious injury or threat to a physical integrity of self or others. Response involves intense fear, helplessness, or horror. One of the following of re-experiencing the intrusive thoughts, distressing dreams or nightmares, flashbacks, distress, psychological distress, or physiological distress to cues. 3 of the following of avoidance of thoughts, feelings, or conversations about trauma, stimuli that arouse recollections, inability to remember, decreased interest, detachment, restricted range of affect, and a foreshortened future. And 2 of the following of arousals: sleep disturbance, concentration difficulties, irritability, hypervigilance, and startle. So there's this new PTSD that's coming out, and it's called perinatal PTSD. And this is when a mother perceives the L&D process as traumatic. It affects up to 6% of mothers in the postpartum population. The risk factors may include a past psychiatric history, past trauma, maternal and infant complications, and the type of delivery. And there was a study that said that instrumental deliveries with forceps are often more traumatic than emergency C-sections, and I can understand why that would be so. But even women with normal vaginal deliveries experience perinatal PTSD, so it's actually the mother's perception of childbirth, that is the better predictor of perinatal PTSD than the type of delivery itself. Some of the clinical features that these patients present with: avoiding the baby, avoiding future pregnancies, avoiding sexual relations, may complain of sexual dysfunction, may avoid other mothers and infants. Generalized anxiety disorder: excessive worry and anxiety for 6 months. They find it difficult to control the worry. 3 or more of the following symptoms present for about 6 months: poor concentration, easily fatigued, feeling restless, keyed up or on edge, irritability, muscle tension, or a sleep disturbance. Perinatal GAD. It's associated with lower socioeconomic status, personal psychiatric history, and a family psychiatric history. In pregnancy, it affects up to 8.5% of women. They worry about things related to the pregnancy: inability to do tasks, clothes not fitting, shoes not fitting, labor and delivery, the health of the baby. In the postpartum period, it affects up to 8.2% of women. And the worry is most commonly related to finances, appearance, and household tasks. So these seem like things that I think any person during pregnancy or postpartum would be worried about. But you have to, especially for PCPs, you got to make sure, or you got to realize that these patients will present with excessive worry. They're going to be a little more worried than all the other patients that you see, and you may spend a little more time with them in the office, and those are kind of some cues to refer to us. Treatment. Thorough history and physical exam. This was drilled into me when I was a first-year resident, and it's totally a reflex, but I think you have to rule out any kind of medical condition with anxiety disorders. Get labs, get medications. Are they on any medications that cause anxiety? Collaborate with the referring physician or the PCP. Make sure you get a thyroid, rule out any dysfunction, and H&H, check for anemia. And the blood pressure, that's there during pregnancy. You want to rule out any kind of preeclampsia. And then there's that zebra pheochromocytoma, which is deadly in pregnancy, I hear. CBT is recommended as the first line of treatment in postpartum anxiety. Well, it's recommended as first-line treatment for all anxiety disorders. So why can't it be used for women in the postpartum period? In panic, CBT, education of the cognitive behavioral model of panic. So you want to make sure that the patient understands this model, and it's the cycle in which the patient feels aroused or more aware of the anxiety, and all these feelings are interpreted negatively, and then they have a panic attack. Cognitive relaxation training, doing breathing, progressive muscle relaxation, cognitive restructuring. It's used to challenge the catastrophic thinking. And what if you gave a talk on live TV in front of a whole bunch of people and you talked too fast or forgot something? What is the worst thing that could happen? I'm not going to get fired, I don't think. And then finally, exposure to the fear. In OCD, you want to reduce the rituals through exposure and response prevention. You want to interrupt the cycle of the rituals. And in PTSD, the CBT used there is basically with reliving exposure and cognitive appraisal during that relaxed state. So pharmacotherapy, primary concerns using psychotropics during, this should be just lactation, so we'll keep to that. The neurobehavioral consequences in infants. There's research developing on long-term effects. The data is limited though. And then toxicity in the neonate. Hepatic enzymes, they develop by 3 months of age, so they're going to have difficulty processing these medications. The American Academy of Pediatrics recommends exclusive breastfeeding for the first 6 months of life and continued breastfeeding through the first year. There's limited data about psychotropics in breastfeeding. In the PDR, which rates drugs A, B, C, and D, and X, this isn't the best source for accurate breastfeeding information. Factors that affect concentration in breast milk, maternal plasma level, it's dependent on the dose, the metabolism and the excretion, lipid solubility, CNS active drugs are highly lipid soluble, protein binding, greater than 90% is preferred in breastfeeding. That means there's less free drug available. And then molecular weight. During the first 3 to 7 days after delivery, there are gaps between the alveolar cells in the breast, and then they close in response to prolactin. So during that time, that's when colostrum comes through. That's when your medications can seep into the neonate. So whenever I was trying to figure out what I was going to do with this woman in her third trimester, and I was going to give her a benzodiazepine after, I wasn't for sure how to do it. And so in my reading, I found there are different kinds of ratios and different kinds of, I guess, tables or risks that helped me decide what I wanted to do with her in the postpartum period. Milk to plasma ratio is something that we look at. It's the concentration in mother's milk divided by the concentration in mother's plasma. This is found in reference texts. Less than 1 is preferred, and a level greater than 1 means that the drug is present in high levels or higher levels in milk. The relative infant dose is the dose in infant divided by the dose in the mother. And this is how much medication an infant is exposed to based on weight. A RID less than 10 is most likely safe, and this is found in reference texts as well. Lactation risk categories. L1 is the safest. It's taken by a large number of mothers. No observed adverse effects in infants. L2 is safer. It's studied in a limited number without an increase in adverse effects. L3 is moderately safe. There are no controlled studies. Possible risks, you've got to weigh the risks and the benefits. L4 is positively hazardous. There's a risk present. Benefits in mom may be acceptable. And L5, contraindicated. Because I was reading about benzodiazepines during pregnancy and during the postpartum period, I came across a little bit of information about oral clefts and benzodiazepines, because that was my original fear. I was so afraid to prescribe this woman Ativan or lorazepam. So in 1975, there was a study that linked diazepam to oral clefts. There were actually 2 studies that came out during that year. And since then, there have been a lot of studies saying, well, yes, it does, no, it doesn't, yes, it does. In 1998, there was a meta-analysis of benzodiazepine use in pregnancy. In the cohort studies, they show no association between benzodiazepine use and oral clefts. In the case control studies, they showed a slight increased risk of oral clefts. But there was a recent study published 2 years ago that shows that there's a higher rate of oral clefts in untreated panic disorder versus panic disorder treated with benzodiazepines. So benzodiazepines actually may be protective of this malformation. So here's a sample of benzodiazepines, and this is kind of what I did. I had a list of medications, and I'm trying to figure out what I could use for her. All of them are all L3 except for diazepam, which is L4, and that's in chronic use. The milk to plasma ratio is relatively low, so you want to go with the lower number. In the RID, you also want to be less than 10. They're all less than 10. Diazepam's not probably the best one to choose because it has a long half-life and it's going to accumulate in the baby. Temazepam, probably. Does anybody have a choice? Mm-hmm. Based on these numbers. Lorazepam. Right. So in conclusion, my patient, after she delivered her baby, she was really anxious whenever she was coming to see me, and then when she delivered, her anxiety had decreased, and she no longer needed a benzo, so I didn't have to make that decision. But thank you, Lane, for doing that. And that's the end I may have spoken a little too quickly. Yes.
Thanks for the overview, the good overview. Question about social and environmental factors, and if there's any knowledge you have of increasing incidence in postpartum anxiety because of too much juggling with environmental stresses of women's roles and having too much to juggle.
Yeah, there's some literature out there that says increasing stress. I mean, there's all the roles influence stress, but there's nothing out there that says they actually meet criteria for an anxiety disorder. It just says
Of anxiety in women. There's no evidence that of an increasing incidence of anxiety in women postpartum.
there aren't any studies that say because of the hassles that are going on, that anxiety disorder, there is an actual anxiety disorder. All the literature says that it increases the anxiety, but there's nothing says they have an anxiety disorder because of what's going on. Yes?
Thank you very much, Betsy. Very clean and good, and you ended early, which is very
Yeah.
You gained points for that. So two questions, somewhat related. You focused on benzos.
Yes,
Would she have been a candidate for SSRIs?
absolutely.
Second question related to that, I'm intrigued by the lactation risk categories. Do you happen to recall where the SSRIs fall in those categories?
Okay, first question. Yes, she's a candidate for SSRIs. Yes, absolutely. And the reason that I went through just to straight to benzodiazepines today is because Dr. Kathy Smith gave a wonderful lecture on SSRI use in pregnancy and lactation. And rather than repeat what she did last year, I just wanted to go straight to benzodiazepines. But yeah, absolutely, SSRIs, definitely. And your other question was for the lactation risk categories? Are they,
The antidepressants.
well, I'm sorry, where are they for? What?
I mean, are they in L2, L3 in that scale?
I don't know exactly off the top of my head, but we know there was a recent study by Wiseman, I think in 2004, that said the medications to use in lactation, the SSRIs to use sertraline and paroxetine. The ones to stay away from are citalopram and, I'm having a blank, fluoxetine.
So which ones seem to be safer?
Sertraline and paroxetine. Yes?
I think you said like a sentence about this. I didn't catch what you were saying at the beginning. Did you make a comment on protein binding in pregnancy?
Yeah, protein binding actually decreases in pregnancy, right? Yeah, so along with the fluid changes that occur in pregnancy and with the decreased binding, protein binding, you may notice that you may have to dose, like if you're giving them SSRIs, you may have to increase the dose, especially during the third trimester, to control the symptoms.
Yeah, and have any data on the SNRIs?
I do not on the top of my head. Yes.
I was wondering, going back to the PTSD thing, you mentioned the perinatal PTSD, but I'm wondering if people have a pre-existing PTSD diagnosis, maybe they're stable or whatever, is there a greater likelihood that they'll have a recurrence of symptoms postpartum?
Oh, absolutely. Absolutely. Trauma is a risk factor for perinatal PTSD, and maybe that window opens up, and then they go back to that original trauma and they experience that more. So yeah, absolutely. Yes, Dr. Trimble.
I was just wondering, was there anything in the literature about the incidence of anxiety with the nulliparous postpartum patient to the mole tip? If you've gone through it once, are you less nervous? Do you tend to have less problems? Or do these people tend to repeat with each pregnancy the same incidence?
I didn't find any literature that differentiated that. Have you?
about that stuff.
No, I didn't see anything in that, but that would be an interesting way to go. Yeah, definitely. I'll let you know, Dr. Trimble. Any other questions? Yeah.
They wouldn't know.
Huh?
I'll ask you separately.
Okay, that's cool. All right, thanks for coming.
And don't forget, Rob,